Welcome to The Explainer, everyone. Today we're going on a really fascinating journey through the kidneys to demystify cystic kidney disease. And, if you're sitting there thinking this doesn't apply to you, consider this. Almost everyone will actually develop at least a simple kidney cyst in their lifetime. We're going to start our journey with those benign everyday anomalies and scale all the way up to highly complex multi-organ genetic syndromes. I am absolutely thrilled to break this all down for you, so let's get right into it.
Here is our roadmap for today.
We'll be covering the basics of kidney cysts, complex cysts and cancer risks, adult polycystic kidney disease, infant polycystic kidney disease, and finally, diagnosis and medical management.
Okay, Section 1, the basics of kidney cysts. Let's dive right into this.
To start making sense of all this, we really have to contrast our two main categories. First up, we have simple cysts. Think of these as essentially harmless, thin-walled, little fluid-filled sacs. If you look at them on an ultrasound, they appear anechoic, which is just a fancy medical term meaning they look completely dark because fluid doesn't bounce the sound waves back. These mostly just pop up as we get older, usually due to minor tubular obstructions that cause a little bit of back pressure. But compare that to the other category, complex cysts. These are the ominous ones. They have major structural changes. We're talking thick walls, septations, which are basically little dividing walls inside the cyst, calcifications, and a really heterogeneous or mixed appearance. Whenever you see a complex cyst, your clinical radar should definitely start beeping.
Moving right along to Section 2, complex cysts and cancer risks.
So how did doctors actually make those high-stakes, life-or-death decisions when they spot a complex cyst? Well, they use something called the Bosniak classification. It's basically a medical decision tree. For classes 1 and 2, we're seeing thin walls and absolutely no vascular enhancement when we use contrast dye. So the action there is simple. You just reassure the patient. But as we bump up to class 2F, we start seeing thicker walls and those septations I mentioned, which definitely prompt some follow-up imaging. Now, the absolute crucial point here is in classes 3 and 4. These are highly irregular, thick-walled cysts that actually enhance with contrast. Why does that matter? Because that enhancement literally means the cyst has a rich blood supply feeding it, heavily pointing toward a tumor. And the action for that? Surgery, specifically a nephrectomy to get that threat out of the body.
If that complex cyst does turn out to be malignant, renal cell carcinoma, or RCC, is the biggest fear we have. The classic triad of signs includes hematuria, blood in the urine, flank pain from the growing tumor stretching the kidney capsule, and a palpable mass. But honestly, this is where it gets incredibly fascinating. Let's talk about paraneoplastic syndromes. These tumor cells essentially go rogue. They literally hijack your body's hormone production and cause absolute systemic havoc. They can produce a parathyroid-like peptide that causes severe hypercalcemia. They can pump out EPO, which leads to polycythemia, meaning a massive overproduction of red blood cells. And they can even crank out renin, causing severe hypertension. It's wild. You have this localized tumor causing full-body hormonal chaos.
All right, Section 3, adult polycystic kidney disease.
When you encounter a patient with massive, bilaterally enlarged, completely cyst-filled kidneys, you're not looking at an isolated issue anymore. It all comes down to a structural error deep in their DNA. Most commonly, we're looking at a mutation in the PKD1 gene, which is located on chromosome 16. This one is the heavy hitter. It causes the disease to show up early in adulthood and follows a very severe clinical course. The alternative, which is less common, is a PKD2 gene mutation on chromosome 4. So the specific chromosome hit basically dictates the patient's entire timeline. A PKD2 mutation generally means a later onset and a somewhat less severe progression. But how exactly does a tiny mutated gene turn an entire kidney into a giant mass of cysts?
Let's look at exactly how this builds molecularly, step by step. Step 1. That genetic mutation we just talked about means the body has missing or broken polycystin proteins. Step 2. Normally, these polycystins sit on the little antenna of the kidney cells, called cilia, and they control calcium signaling as fluid flows by. Without them, that signaling is just utterly absent. Step 3, because calcium is normally the signal that tells cells to stop growing, the lack of calcium leads to uninhibited cell proliferation. The tubular cells wildly multiply and create these blind sacs. And finally, step 4, a hormone called ADH causes aquaporins to continuously pump water into these brand new sacs. It is the ultimate plumbing disaster. Broken signaling builds a faulty tank, and then overactive ADH just leaves the hose running, completely ballooning the kidney with massive cysts.
And those ballooning cysts don't just damage the kidney, they cause massive, massive downstream effects. First up, chronic kidney disease. These gigantic cysts physically compress the neighboring blood vessels, starving the working nephrons of oxygen, which causes ischemia and tissue death. And that exact same vascular compression triggers the kidneys to completely panic and release renin, jacking up the blood pressure and causing renovascular hypertension. Also, remember, the polycystin mutation affects connective tissue body-wide. That is exactly why we see benign cysts randomly popping up in the liver and pancreas. But most terrifyingly, this systemic connective tissue weakness dangerously predisposes the blood vessels in the brain to intracranial aneurysms. It creates a huge risk for a fatal subarachnoid hemorrhage.
Lowering the tone slightly here as we move into Section 4, infant polycystic kidney disease.
Shifting over to the absolute most severe end of the spectrum, we're looking at autosomal recessive polycystic kidney disease, or ARPKD. This tragically presents in infants and even in utero. The crucial point to understand here is that we're dealing with a completely different protein. In infants with ARPKD, the mutation is in the PKHD1 gene on chromosome 6, which encodes for a protein called fibrocystin. Unlike in the adult version, fibrocystin is absolutely essential for the normal development of both the renal tubules in the kidney and the biliary system in the liver. So mutation here guarantees catastrophic simultaneous failures in multiple organ systems right out of the gate.
Let's actually look at what happens in the liver first, because it's devastating. The lack of fibrocystin causes severe congenital hepatic fibrosis, meaning the baby's liver becomes incredibly scarred and stiff. Imagine a major plumbing highway getting completely clogged. Blood trying to flow through the liver just backs up. This creates portal hypertension, and that extreme pressure forces blood backward into the spleen, causing splenomegaly, and pushes it up into the incredibly fragile veins of the esophagus, causing life-threatening esophageal varices.
But the most immediate threat to an infant with ARPKD actually happens before they're even born, all due to something called oligohydramnios. This is a dangerous, severe deficiency of amniotic fluid in the womb. You see, amniotic fluid is largely made up of fetal urine. It's wild to think about, but it's true. If the fetus's cyst-filled kidneys begin failing in utero, they just stop producing urine. The amniotic fluid levels drop drastically, and the physical consequences of this are absolutely devastating for the developing baby. Chronologically, this creates a heartbreaking, fatal cascade. Step 1, the kidneys fail in utero. Step 2, this directly leads to that oligohydramnios we just discussed, the lack of amniotic fluid. Step 3, without that protective fluid cushion, the uterine walls physically compress the growing fetus, which causes cranial anomalies, facial anomalies, and clubbed feet. But step 4 is the really lethal blow. The lack of fluid and the physical compression completely crush the infant's lung development, leading to pulmonary hypoplasia. So ultimately, it's actually this respiratory failure, not just the kidney shutting down, that is the most common cause of mortality in these infants the moment they are born.
Taking a deep breath after that heavy pathology, Section 5, Diagnosis and Medical Management. Let's talk about solutions.
So how does medicine actually identify these diseases and fight back? Well, when a patient presents with symptoms like flank pain or hematuria, the clinical approach has to be super systematic. Step 1 is evaluating that patient presentation. Step 2 is a simple, non-invasive renal ultrasound. Honestly, it's virtually always the diagnostic test of choice. It quickly tells us if we're looking at a simple cyst, a complex cyst, or enlarged polycystic kidneys. Step 3. If we do spot a complex cyst that looks suspicious, we immediately escalate to a CT scan with contrast to check for that vascular enhancement we talked about earlier. And Step 4, especially for the polycystic diseases, involves deep genetic and family history screening to assess hidden risks, like those intracranial aneurysms. So, think back to our molecular plumbing disaster from earlier in the explainer. If the hormone ADH is continuously leaving the hose running, fueling cyst growth and filling these massive kidneys with fluid, how do we stop the flooding? Is there a pharmacological way to just turn off the tap?
The amazing news is we can actually counter the pathology directly. Problem 1. ADH driving cyst fluid. The solution? A drug called tolvaptan. It specifically blocks those ADH receptors, effectively shutting off the aquaporins so the cysts stop filling with water. This literally slows down the physical enlargement of the kidney over time. Problem 2. Enormous cysts are compressing vessels, causing ischemia and huge renin spikes, driving up blood pressure. The solution here? ACE inhibitors, or ARBs. These drugs block the downstream angiotensin II, forcing the blood vessels to relax, dropping the blood pressure, and protecting the remaining functional nephrons. It's incredibly satisfying clinical pharmacology.
Of course, for our infants with ARPKD, the medical management isn't just about throwing a pill at the kidneys. It requires highly aggressive critical care across multiple organ systems just to keep them alive. We use ACE inhibitors to manage their extreme renal vascular hypertension. We use beta blockers to lower the portal pressure in their fibrotic livers. If they develop those dangerous esophageal varices, doctors go in with endoscopic ligation to physically tie them off and prevent massive bleeding. And critically, because of the pulmonary hypoplasia, these infants almost always require immediate mechanical ventilation for respiratory distress the absolute second they are born. You have to aggressively treat the lungs and the liver right alongside the kidneys.
We have covered incredible ground today, moving from a simple, age-related fluid bubble to massive, multi-system genetic cascades. But I want to leave you with this final provocative thought. As genetic therapies rapidly advance, will we eventually be able to repair these exact polycystin and fibrocystin mutations in utero before the very first cyst even forms? The potential to stop the plumbing disaster before the pipes are even laid is the thrilling frontier of genetic medicine. Imagine that. Keep learning, keep questioning, and I'll see you in the next explainer.